So we don't need to be in it. That's just you three.
Are you happy with that, Fred? Just what we did before. We just fired questions from the back.
Anyway, I'm Chris Taylor. I'm consultant plastic surgeon working in Plymouth, Derriford, down in the southwest. I specialise in sarcoma surgery and also lower limb trauma. I'm an ex-military army surgeon, retired from the army about 4 or 5 years ago now, and been a consultant for 10 years.
I'm James Coelho. I'm a plastic surgeon again in the southwest in Plymouth, and I've been a consultant for 3 years now. And I specialise in breast surgery, autologous breast reconstruction with DEP surgery mainly. I work with a very good colleague of mine, John Dixon. We do all our cases jointly. And I have an interest also in lower limb reconstruction and perineal reconstruction as well.
Hi, I'm Alex Armstrong. I'm a consultant plastic surgeon in Plymouth. I joined there in 2021. I describe myself as a fairly general plastic surgeon. Got two-thirds paediatric and 1/3 adult practice, which focuses on paediatric hand conditions and hypospadias, adult hands and lower limb.
What's the best part of your week?
Well, I'd say probably Tuesdays actually is quite a good time because we're quite a collegiate department. We have a weekly consultant meeting. And I think one thing I found when I first joined as a consultant is quite isolating, quite lonely.
Right.
You know, when you're a registrar, you're part of the pack. You're in the reg room and you see everyone, and then you become a consultant, and then literally you're kind of like on your own. And it's a bit isolating, but I think it's quite good in our department. We get together, all of us. You know, I think that's pretty good, really, because we get to chat about cases and what's going on, and it just keeps us all as one unit.
It's quite like a safe environment that you can talk about what you want, ask for advice. We kind of have an expression of a problem shared is a problem for two people.
Yeah.
We're quite happy to, air our dirty laundry, talk about complications, get advice. I think we're quite candid as a group, and there's kind of no shame in getting extra people involved with cases. And we do a lot of heavy lifting for each other, covering things. So we're quite cohesive.
How do your personalities come out in your work? You mentioned you're ex-military. Do you think that has an effect on the way in which you work?
I don't know really. I wouldn't say I was sort of like a classic military surgeon as people might, imagine. I'm quite a reflective person, so I'm quite candid, as you were saying, and quite open in theatre, and about actually sharing the kind of stresses of cases, and trying to impart that on my trainees, that it's actually not always just about the technical stuff, it's the soft stuff of managing, difficult cases mixed in amongst, routine cases.
Personalities, I think we've got quite varied personalities amongst the group. We all rub along, but it's actually, it's quite healthy to have differing opinion, and that is embraced quite a lot actually, because there's a little bit of a split of the older, more senior consultants we lean on for a particular advice, and then probably we've become more proceduralists in terms of taking on those bigger cases, but we feel supported with that. But there's definitely pretty broad personalities, but everyone we kind of embrace those differences, I'd say.
Chris, last night you were explaining your kind of strategy for recruiting the new consultants. You wanted microsurgeons specifically. Can you talk a bit about that?
Well, I think it's a little bit by design, I guess. I think if you look at the surgical subspecialties that you offer as a department and then recruit to those surgical specialties, you just create lots of silos of hand specialists and paediatric specialists. But I think we kind of set about trying to recruit generalists and microsurgeons, capable microsurgeons really, who could lend a hand to doing breast reconstruction, but also offering perineal reconstruction and lower limb. And so really setting about not just like, let's get a hand surgeon, let's get a hypospadia surgeon, let's just get general microsurgeons who are young, dynamic off the top, and actually enthusiastic to get out there and work with all the other subspecialties in our hospital and just offer very capable plastic surgery reconstruction, and I think that's what we've kind of got.
I think it's a core skill that's needed in our department. I think it's a general skill that we all need, and that means that you can go and work with neurosurgery, cardiothoracics, whoever it might be. And those are the cases we go as two consultants to those particular cases.
Do you ever go as 3 consultants?
Well, actually, quite often.
We have done for some of the maxillofacial reconstruction, as we've tried to bolster that service as we're recruiting into that service as it's developing.
We have some complex trauma cases that we've worked together as well. I think the other thing to say about Derriford Hospital and Plymouth is that it's sort of everything, all the specialties are under one roof as well. So it's a nice thing to be able to offer and be those people who can say yes to things as a group of surgeons and help the other subspecialties. It's one of the things I love about plastic surgery is working with the other specialties.
Yeah, that's the best thing about our specialties.
Yeah.
I think that's one of the reasons why we've become such a collegiate unit is because we've all got shared interests and shared cases. We all do chest wall reconstruction for the cardiothoracic surgeons. We've all done some neurosurgical reconstruction. So we've all done a bit of perineal reconstruction. We've got involved with the ENT surgeons doing head and neck cases. We all do orthoplastics. So actually we're not working in our individual silos, always coming in from our own side of subspecialist interest, but actually we all share it, so it's like really genuine.
Do you all do yoga?
Yeah, that's been born out of an idea that my colleague John Dixon and I had about a year ago, and it's something which has worked really well in the breast reconstructions that I do. So at the beginning of a DEP case, we get in fairly early at 7:45 to 8 o'clock, so it's 15 minutes of time for the team. We invite the whole team. Frequently the anaesthetist doesn't manage to make it because they're seeing a patient at the time, and they miss out slightly. But most of the rest of the team come. So we're really lucky to be funded by our wonderful breast charity, the Primrose Foundation in the South West, and they funded the yoga mats and so we do that before every DEP.
Yoga mats in theatre?
In theatre, yeah.
So you push the table out the way?
The anaesthetic machine gets pushed slightly away, just about safe enough so the tubes are still attached, and the ODP can do the checks if they feel they need to at that point. But we dim the lights, and it's a nice time. So
Lavender?
Tincture bells.
Singing bowls.
Exactly.
See nearby.
I've not actually witnessed this. I must come along and see, but it's...
And do you lead on that, do you? So
Yes, I lead. I by no means am a yoga instructor. I hadn't done much yoga, if any yoga, almost before. I've done a bit of Pilates, almost. But the yoga part of it, we have a big screen in front of the theatre, and we use that, and we normally get someone on YouTube to kind of instruct us on a 15-minute or 10-minute session, and we kind of try and vary it up a bit.
Yoga with Adrienne.
Yeah,
very good.
Yeah, at one point in 10 years' time, we'll try and invite her down for a session.
I might come and watch.
Yeah.
But you would, sorry,
we can combine that with our visit. Tell us when she's coming. And
Absolutely. We do every 2 hours we do pressure relieving for the patient, and at that point it's tools down for everyone if we can. It's a safe time to do that, and we ask everyone to look to the four corners of the room, stretch, a bit of time for themselves just while that movement is being done, because that movement can be quite distracting as a microsurgeon and doing whatever we're doing with the patient. And it's actually that time is quite important, because actually it helps you think about what you're doing as well. It's time mentally as well to think about, well, where am I in the operation now? Everything's quite fast, surgery, you want to get to the end, but it's really important to kind of piece together exactly how you're doing it and make sure you do it well and what your next steps are. And actually, you're not losing time by taking this 2 minutes.
And who keeps track of that time?
So that's kept by one of the HCAs, and they log this all up on the board, so it's very clear.
We want good people to work with us, so there is this congeniality. There's obviously you have to have boundaries and some form of professionalism around these structures, but we want good people, and you only get that by learning from your trainees as well. We've got some very good trainees, and there's no shame in asking a trainee, what would you do here? Because they may know a lot more about that than you do, coming from other places in the rotation. So we're quite, I think, wary of hubris and all those sorts of things that can get in the way of bad decision making, and empowering the trainees to do that.
Do you have fun at work?
Oh, for sure.
Yeah, definitely.
Daily. I wouldn't do it if I didn't. I really enjoy the work, enjoy the team, and enjoy living where we do as well. I mean, that's a big part. For a lot of people who live in the southwest, I think that is a big attraction. But I mean, the team there are excellent, and everyone is very supportive of each other.
Do you laugh a lot? Alex used to make us laugh a lot. Well, he still does.
The village idiot, he tries to say.
No, genuinely.
Cool jester.
Yeah,
We do.
I think you've got to, haven't you? Because that's a pretty wearing. It's a marathon, not a sprint. It's supposed to be a 25-year job, and we're wary. We talk about burnout and symptoms of that, and we've got really good leadership in our department at the moment.
What do you think are the most important things about good leadership?
Or not feeling that you have to solve every problem yourself, probably, and that actually you're just a focal point for all of the other good ideas. For every other people, you're surrounded, inevitably by very, very skillful, capable people. So just because you are in a position of leadership doesn't mean to say you have to then take responsibility for everything. So learning how you get the best out of the people surrounding you, and sort of using their skills and attributes is probably the best.
What does it mean to each of you now to be a plastic surgeon?
Well, difficult question. I think it is the best specialty, because children, adults, very varied. It's like kind of the last bastion of general surgery. But to be honest, to me, it's the interactions with patients. You get let into a lot of their lives. They're going to trust you, and you go through highs and lows. So you get people at their lowest ebb, and you've got to try and support them through that. And they've got to tell you a lot of information, and you've got to, you're in a privileged position to be able to care for those people. So I think it's still the human element, I think, as a plastic surgeon, in reality, for me.
I think in my training I did a lot of general surgery, I did orthopaedics for a while, I did ENT for a while, and I think I was really happy I did all those, because it made me realise that actually Coelho and Alex plastics was the best for me, and I feel that working with the other specialties I love doing, and very lucky to work in such a supportive environment. And I think the impact that we have on patients' lives is mainly quality of life improvement, and that's a really important thing, especially when we work with breast ladies. And it's rare almost that we can save a life, but I think we improve lives all the time in our specialty, which I think is a great thing.
I've been hearing from Chris this morning, just saying we've got these diverging directions of travel. We've got patients becoming ever more ill with comorbid disease, whilst as doctors we're becoming more and more subspecialised into our individual silos. One thing I love about being a plastic surgeon is it's still very much a general surgical specialty, which is about problem solving. You're not really defined by your 4 or 5 operations that you do on a weekly basis, but you see a patient in clinic and it's kind of like problem solving quite a lot of the time, and how you're going to, as you say, improve function, improve form for them, and that being there on standby for all the other surgical specialties that have problem cases and helping them out. So that's just being one of the last generalist specialties.
I liken it a bit to rheumatology of surgery sometimes, because if it's a bit tricky, or we're not sure, we've run out of ideas, or we don't know the diagnosis, it comes to us.
Yeah.
And sometimes the rare becomes common to us because we pattern recognition, especially in children's surgery. You get referred children who've got a congenital condition and people can't quite put their finger on it, but because it filters to you, you see it more commonly. And actually, you might not need to do anything, but it's actually presenting the diagnosis and all that sort of stuff to the family and giving information about the prognosis is quite a medical aspect of the specialty as well.
Yeah. Brilliant. That's a wrap.
It's really good. Yeah.